Thank you, Janice. Good morning, everyone. It's just a pleasure to be here today. So we're going to start talking about getting youth and young adults to be on track. And so I'm going to start with a metaphor, and really transition is about getting young people to move from the passenger seat in the car into the driver's seat. So if you think about, the transition through life, you start off with a young child and they're in a specific child seat. They move into the passenger seat with the parent driving, and then they have to move into the driving seat. And the process of going through that is that you get a license. Well, nearly half a century ago when I learnt to drive, my father pulled the car out of the driveway and we spent half an hour working out how to use the clutch. Then we drove around the block a few times and into town. I did a test and I was driving. And I had 3 crashes in my first year after I had learned to drive, and since then I've had a safe driving record. Well, today, when you learn how to drive, it's a whole different process. Firstly, there's a manual. Secondly, you have to undergo a theoretical test. Then you get your L's and you have to practice, often with a trained instructor. Then you have to practice driving with your N plates for a year before you can sit in the driver's seat. So when we're looking at transition, I want you to think of that as we move through the slides. So what I'm going to speak about really is the manual and how it was developed and how our health services work. So really about sort of the roads and rules of the road and the framework with what we're dealing with. And Mary's presentation will be more on the actual putting the young person into the driver's seat and all the tools and resources we have for getting them to how to drive. And then Bryn will be speaking about his experience going through that journey. So I want to start with some results from BC. So Mina Matsuda, who was a pediatric renal physician here until a few years ago, looked at developing a transition clinic in the renal clinic at BC Children's Hospital. And when she came, she did a retrospective study, and of 33 patients who had renal transplant, unfortunately there were 3 crashes with mortality and 7 significant issues with allograft losses in the 2 years post-transition to adult care, and these were all unanticipated. Introducing a transitional care clinic into the hospital reduced that mortality to 0. Now the numbers are small, but it shows that really thinking about this era, and we look at it again, young drivers are the ones that are most likely to crash. We need to help them, support them through that care. So ONTRAC is a provincial-wide program that is looking at transition, and the circle slide on your left-hand side reflects that transition is about a whole process, and then within that there is the transfer of the patient, and within that there is the handover process. So you've got to look at it sort of as a bigger, like all these rings of an onion. And the transition process itself is to ensure successful planning and preparation, that's the manual, and transfer of youth, that's getting the licence, for youth with chronic health conditions and disabilities from paediatric to adult care. And then we need to make sure that there is attachment into the adult system. That is, that the young people keep following through as the young adults. So one of the things that's really important is the difference between paediatric and adult care in the healthcare cultures. And paediatric care is more family focused. It's usually multidisciplinary, and I know some of your adult teams are also multidisciplinary. But that's a really big feature in paediatric care. Usually parents give consent until the young person is able to give their own. I'll talk a bit about that later. And it's developmentally oriented. So we're always forward thinking and actually very optimistic. Whereas in adult care, often the focus is on prevention of long-term complications. One of the other differences between paediatric and adult care is a little bit like the differences between elementary school and high school, and I think this is a good thing to sort of think about when speaking to patients. In elementary school, you have really a single teacher, and you might go have a different teacher for gym or music, but really most of your care is provided in one place. When you go to go to high school, you have different teachers for each different subject. And you don't go to your maths teacher for English and your English teacher for gym. You have different, and you might like one teacher better than another, but the care is less, the teaching is less centralised. And so when we speak to young people about that shift from elementary to high school, that's something that they can better understand about the different cultures of care. So what we're interested in transition is improving the patient experience and for patients and as well as for providers, because adult providers are often challenged by accepting patients that have been in that paediatric system and have lots of expectations when they come to adult side. And I think that there's different levels of engagement. So, it's really vital to look at safety and basic care needs and to get patients prepared, but we need them to be connected to the adult system and feeling engaged. And there are some issues around health literacy and engagements, particularly that Mary will talk about how important those things are. When we look, so I'm just sort of going to step back a bit and talk about the framework. It's a little bit dry, but I think it's important to sort of understand the health system that these young people are navigating through. So in 2011, we started with a provincial workshop and we came up with these 3 circles, that there was paediatric care, family practice, and young adult care, and that this was sort of a framework about how there was overlap. We realise now that it's much more complex than that, but it was a starting point, and it shows that there are these, that for transition, you're moving in between all of those areas. And so what tends to happen actually is there is a gap. But if you look at these 3 circles, the most dense care needs to be at that handover or transfer time. So that's where the overlap needs to be during transition. So we were very fortunate, there's more interest in transition now, and we were very fortunate that the doctors of BC felt that this was a really important issue, and in 2012 a policy paper came out that was around transition in general, and some of the important parts of that is that all patients should have a family doctor, even if they're receiving specialty care. And then in the paediatric setting, an adult healthcare provider should be identified about a year prior to transfer. And when you think about sort of time it takes to make a first appointment and things like that, it's really important to get the young person engaged in what's going to be happening in the adult system. And so one of the other things, and when I said that it's actually a much more complicated system than those 3 circles, when we looked at what ONTRAC stands for, it stands for Transitioning Responsibly to Adult Care. So you want to stay on track, but we took the R of responsibly and thought, what does that mean? What is transition? What are the features of transition we need to consider? And it ends up being incredibly complex. We need to think of the roles of the different healthcare providers, the roles of the parent and the young person, and how those roles are going to change during transition. The research is really important because it gives us data. We need to think about young people's rights, and that's where consent and confidentiality comes into play, and whether young people are seeing the doctor by themselves in the paediatric setting, and who's sort of taking control and how the young person can advocate for themselves, especially with the speaker who spoke last about quality of life and patient needs. How do we get the voice of the young person involved, to be involved in their care when they're a parent and youth together? We want to look at the outcomes. What are we aiming for in transition? And one of the things we talk about is 2 successive appointments with an adult specialist and engagement with a family doctor. But what makes it, what sort of success are we looking for? We've got to be realistic because the system is challenging and we're in process, so we're still learning. The issue around healthcare records is very important. Who gets the information? And you have a wonderful promise system that helps you have information provincially, so you're ahead of the game compared to many other specialties. Relationships are important, like roles. What resources are needed? So now that transition actually takes resources because it takes resources to learn how to drive. So what are those resources? How can they be used most effectively? Mary will talk a lot about resources. How can we be be respectful of everybody. So that's particularly looking at often the relationships between different providers and being respectful that when we send information to them that it's in a form of communication and that we both provide enough anticipatory guidance to, say, family doctors or other healthcare providers without sort of overtaking their care. So how can we have those respectful relationships? Risk and resilience, what makes transition easier for some and not for others? That's something we haven't looked at, but it's really important because we know that resilience in adolescent health is a really important factor. So how do people overcome challenges? It's something we need to look at. There's resistance to moving from the pediatric to the adult system by everybody. So so there's this fear of, well, how is that going to happen? So how can we address that resistance and turn it into something positive? Healthcare regions are important. Care is different in the urban centres to rural centres, so we need to accommodate for that. And then also we've got to think about, for some of our patients, the range of cognitive abilities is really different. And so, one of the things that people talk about transition is a young person being able to manage their own care, but in some situations that's not possible. So we took all of this, and it is very complex, and we started to break it down into these green boxes on the side. What's the information that needs to go? What's the most vital parts? How is it going to happen? What are the processes? How can we engage people like you and others in the province to understand that this is important and bring them to the table because we are dealing with the crossing over and in-between space? How do we get collaboration and buy-in and meet different people's needs? And Mary's done an amazing job with that, and we'll speak more about that. And so we've looked at health services and health systems. We've really engaged youth and family in a very big way, and we've also looked at how technology can help, particularly with young people, how we can engage them with technology to be more involved in their care. So it looks like it's really a tough area, but it's too important to ignore. So we're moving along. So this is my last slide, and I just want to sort of say this is sort of an overview picture of how we've looked at the healthcare system. We have, lots of challenges when young people move from Children's Hospital into the healthcare regions that we can't track them. Your promise system can, but we can't track them, for example. So what sort of system drivers do we need? What resources and educational skill building do we need? We've started to talk about standard transfer documentation, provincial transcription services, trying to work out some standards around what has to go with the patient. And we don't want to give the adult providers reams and reams of information, but what are the core important points that need to be transferred? The community and youth engagement piece is really important. We know that half of the young people, 50% often don't make it to their first appointment in the adult specialist care. So we're working on, instead of dealing with this in a one-to-one basis, but in workshops and with engaging youth. Mary will speak more about that. And then so my sort of last take-home message is around the most responsible physician and physician attachment. We know in Children's Hospital that most patients say they have a family doctor. When we ask them about when they last saw their family doctor, often it's a year or two ago. I think we need to really work hard in the paediatric setting, but also as patients move across and in the adult setting, to talk about the value and importance of a medical home, the role of the family doctor, defining what we do in our care and what you will do in your care, whoever you are, and however that will be. And the family doctor needs some role in the patient's care. So how can you work together to define that? So what we've also found is, even though that the families don't see their family doctors very often, they really often feel very comfortable with that family doctor and feel that that's their family, that's their medical home. A last point about family doctors is we need to make sure that the young person is happy with the family doctor that was the family's family doctor. And we don't want the family doctor transitioning at the or transferring at the same time as the patient is transferring, because that just disjoints care more. So I think discussions in the pediatric setting about the family doctor are very important, and then throughout adulthood, that engagement of what the family doctor means. The last piece I wanted to mention was transition care management plans. So with two other specialty groups, neurology and cardiology, we are bringing pediatric and adult providers together, specialists and allied health and family doctors, to look at the processes of handover and transition planning. So if you have a certain type of kidney disease, how far along are you? What type of adult provider do you need to see? How much allied health support do you need? When should the adult appointment be? And because what we're finding is that rather than just having a handover, we're creating a plan which will be available online provincially for providers and also accessible for patients, that will outline a process over transition. And for nephrology, that might be an interesting, we have a prototype or a standard way of now looking at that. It might be a useful tool. So I'm going to stop there, and I hope that at the end that you really feel confident that you understand how to help young people move from being a passenger to the driver's seat. Thank you.
Thanks, Sandy. I'd never heard the car analogy, so that'll be a mainstay now. So unfortunately, Bryn was not able to come today. He got a job, and he started his job today. But he very, very much appreciated the invitation, and he so much wanted to share his story with you that he's passed that on to me, and I'm going to share that with you. So if we look at preparation, transfer, and attachment, Bryn's preparation. I remember when I first went to BC Children's Hospital for the first time. I had to have surgery for the removal of a Wilms tumor. BCCH had a really nice family feel, especially in the clinic. In grade 11, I had a knee injury from football. Blood work revealed kidney issues. It was hard to understand. I went in with a knee injury and learned that I was in kidney failure and really seriously ill. I remember the clinic team really wanted to help me live as normal as possible, even though I was getting very sick. They accommodated all my team sports, hockey and football, kept me playing sports, and worked around my schedule for clinic appointments and tests. I came to hospital twice a week, but they clustered the appointments so I would not have to miss too much school and I could graduate. After graduation, I was much sicker. I started dialysis. I needed and received a great deal of emotional support. There was a huge amount of teaching around kidney failure, blood tests and levels, medications, side effects, and symptoms. Most of the time, staff talked to my mom and dad. We felt I was too young and too sick to understand all that was going on. If I could go back, I would ask more questions about what was happening to my body, transplants, and what the future holds. In my pictures in my grade 12 year, you can tell I'm getting sicker. I went to BC Children's Hospital 3 days a week for 4 hours, and I became very close with the nurses and clinical teams. If I had any recommendations to give the pediatric team at Children's about transition planning and what families need, it would be to explain, without the patient, me in the room, why the transfer between hospitals was happening and in great depth, not just because he's old enough now. Transfer. I had a quick transition or transfer from being healthy to being very ill, and from BCCH to adult care. I was transferred to St. Paul's in early fall, continuing to be very ill, and continued on dialysis for about a month. The search for a kidney donor was on. Dad was tested as well, but not a match. My mom was cleared to give me her kidney. It was a huge transition going to adult care. It was intimidating, much bigger, not a lot of introductions to physicians, very busy atmosphere. Went from knowing first and last names of physicians and nurses to not knowing who would be providing my care. Difficult to gauge who my physician was, and at BC Children's, I had only one specialist to see. You could tell they were not used to dealing with young people in the adult hospital. I went from being a boy to a man's world and was expected to understand what was going on and what was expected from me. I was continually asked questions from my chart that I had difficulty answering or did not understand. I felt like I went from being treated as a child to all of a sudden being an adult. I was spoken to as a full knowledgeable adult, and I was still trying to learn what was going on. The high-level adult conversations made it difficult. Many times after a meeting with a physician or a nurse, I would have to look to my mom and dad to explain what had just been talked about. In my meetings at Children's, they talked to me like a 17-year-old or a lot younger, in words and explanations I could understand. I want to say, I would feel quite badly for a patient who had to go through the transition I did without the parents I have, a dad with a doctorate and a mom who is a nursing instructor. Attachment. I am now 27 years of age. I have been in the adult system for about 9 years. Early on, I was ill, in and out of hospital for a year. I have seen many, many physicians over that time, but over the years, they have gained a strong relationship with the adult nephrologists and team. I play national level sports, playing for Team Canada, learning how to take care of myself. I'm a competitive skier, very aware of when I'm getting ill or something is going wrong. Clinic days are very busy, and I now understand how it all works. I am now that patient that goes to clinic healthy, with solid levels, and taking care of my body. As you can see, I can talk to the physicians, and they respect what I have to say. When I identify that something is wrong with me, they listen. I only now feel I can talk to them as an adult and be part of the clinic conversations. I now understand how to keep myself healthy and take care of my kidney. I take my health very seriously, as it is a gift from my mom. I got involved with the BC transplant through my friend Eva, author of 65 Red Roses, sharing her story about living with cystic fibrosis. Eva hosted a photo shoot at her house and invited myself and a couple of other youth who had transplants. She painted my kidney where it was transplanted, and the photos were distributed nationally to create awareness for transplants and the need for living life and passing it on. I'm sorry I could not be present with you in person today. What I wanted to share my journey with you so you can continue to help others understand how hard transition can be. And in Bryn's own words,
hi, it's Bryn Williams. I'm glad you were able to hear a bit about my life and my story today, but also to hear what it's like going from a young boy who knows very little about why he's sick or why this is happening to him to an adult hospital in a matter of weeks, expected to understand all the terminology and what is going to happen in the future. I want to thank all of you for your ongoing love and care that you provide us when it feels like life's at the absolute worst and there's no light at the end of the tunnel. You change our lives and our family lives forever. Your awareness of how hard transition can be for patients is incredibly important for us to understand this big, scary world they call transplant. With all my heart and gratitude, my family and I thank you for your ongoing care.
so that's Bryn's message to you today. So with putting the message and the direction from youth and young adults and families first and foremost in transition planning, we try to move ahead and try to make some changes that will best suit their needs. So we start with clinical guidelines, core recommendations, guidelines on how we should provide care. And at BC Children's Hospital, we're developing clinical practice guidelines. Basically, it's 7 core recommendations, and I've highlighted a few of them here and showing you how they align with your best practices for kidney care in BC. Patient-centered. We've heard a lot about that already this morning. I think, and Sandy brought up, the important part to note is our youth that are coming out of Children's also come from a community as very family-centered care. Youth rarely have made their own consents. Families are very engaged. And if you think there's a difference or the families fall off at 18 because they now are an adult, they don't. If anything, families get more entrenched and more controlled and more wanting to be involved in the process. So we'll talk a bit more about that timeline. We want to make sure that youth have ongoing care, continuous care. a big part of that is the family physicians. We've been learning about that. What Sandy alluded to was a lot of our kids either decide at 14 that it's not cool to go to mom and dad's doctor. Some of their issues would be sexual health and drug-related questions or mental health, and they may not want to go to the same physician the parents go to. We also know that we have a huge issue around having a family doctor in your own community, in this province. The other thing that happens is sometimes when our kids get sick when they're really young, they come to Children's Hospital because a pediatrician has found something a little bit questionable, and then they get absorbed up and taken up by our subspecialty teams. And we do a lot of this, and we hold really tight. And so sometimes our families don't bother to go see their family docs, so they lose that connection, and it's that connection that they have to have at 18 to make sure they get referrals to adult specialty care. So we're really working hard to build that back into our models of care at Children's Hospital, identifying every time when they come through the door, who is your family doc, and is it the right Dr. Lee? So we want to make sure that happens. Because, anyway, we lose track. And then we also find out that those docs aren't being engaged. They're not even getting the clinic letters just because of systems, it's going to the wrong person, not because they don't want to be engaged in the care. Sandy talked a lot about that one of our projects is with the doctors of BC and going out into the communities. Dewey Evans, our project lead, has been meeting with the divisions of family practice, and again, they say, we want to be involved in their care. Tell us how. So we're building those bridges. And when Sandy puts out the map of all that we're doing, there's only 4 of us. So it sounds big, but there's only 4 of us. We identify a family adult specialist 1 year prior. Families get a sense that they're going. We hear again and again, oh, I just found out at that visit that that's my last clinic visit. So we've got to create that anticipation that they are going to be moving out by the time they're 18 years of age. Focus on self or co-management. Some of our kids are very ill. They never will be self-managed. It will always be in relation to the family. How do we do that? We build skills, knowledge, education. And that, I'll go back to that. The other piece is documentation. Continuity, communication. It came up this morning again and again. If people are really sick, how do we make sure that information is being passed in a standard way that people understand? And that's to all of the stakeholders. It's to the family doctor, the adult specialist, and in some cases now we're finding that the letters and certain documentation is going to the youth themselves. As Sandy talked about, they do fall out of care. If the youth themselves have that information or their family doc, at least we can track that information for them. So we look at a timeline. I think what's important to think about when you look at a transition timeline, look at the age there, 12 to 24. So the first thing we did is we broke down, we got into our cars, moved away from Children's Hospital and went out into the communities. We went in to talk to the family docs, rehab specialists, many meetings over at St. Paul's, VGH. We've had a lot of input from physicians, nursing, occupational therapy, physiotherapy, dietitian, social work. If I leave anybody out, I feel terrible. We've also had a lot of focus groups with youth, young adults, and families. And every one of them say, they're not ready when you send them out the door at 18. They are transferring in the middle of their transition period. How many in the room live with a 17 to 24-year-old? How many of those individuals are very independent, make decisions on their own, get to all their appointments, drive themselves there, deal with complex issues? No. I mean, I think what we're learning too is the age could be pumped to 30. But anyway, at some point from Children's, we have to say, you need to move forward. But I think it's so important that everybody really understand we're transferring them right in the middle, in the hardest time. Because what else is happening? They leave high school. They are going to college. Now they've got to navigate all of that, plus their illness. One of the things that we talk to our kids a lot about now is when you sign up for college, make sure you go for special accommodation. through the Disability Center in most of the universities. Because even though your illness is invisible, if you get sick and you haven't done that special accommodation, you can be failed. So if you can't get to that exam or write that paper because you have a flare-up or something goes wrong, you can be failed. So now that's part of our teaching. So it's really important that we look not only at all the medical changes that happen at 18, but what are all the other things that are going on in their lives? It's really important. So quickly at the timeline, we're starting at 12. We know we have to do a way better job at children's, and we have to start the conversations at 12 years of age. We're building a pathway, which I'm going to show you. We talk about identifying the family doc. 14 is about the age that they start to not want to maybe go to their family doc, and we're saying for sure that's when you have to make sure that it's the right family doc. Readiness skills. So readiness, self-management, developing that skills and knowledge that help you interact in the healthcare system in the adult world. Go into that a bit too. The medical transfer summary, that's that documentation piece that transfers from children's to the family doc and to the adult specialty teams. And I'll go into that in a minute. And the attachment Sandy talked about. When we first started, we knew we had to focus on the prep part and the transfer part. What we're really starting to learn about is attachment, and that's really moving us forward. What does that look like? Not only as getting them to those visits, so that 50% get there, and it's 38% get to the second visit, but also what does attachment look like? And that's a whole new area of study. How do they start to build that relationship with you, adult providers that are in the audience here? So we can do that research collaboratively. So these are our tools, our transition pathway, simple and complex. The simple tool is one diagnosis, cognitively at grade level and physically able. Then we have a whole other set of youth that leave Children's Hospital that are complex. So they may have comorbidities, they may not be cognitively at grade level, they may have physical disabilities, they may have a trajectory of their illness, they may have mental health issues. So we have more work we're doing with that population. I'm going to show you our family and youth readiness checklist, the medical transfer summary, that comprehensive letter, and Sandy spoke to the transition clinical management plans. So here's your kidney or renal specific transition clinical pathway. The highlighted areas in the yellow make it unique to the clinic. This is a standardized tool that we're running across all of our clinics at Children's. We didn't say, but 1,700 youth a year leave BC Children's Hospital needing ongoing care, and that's rising up about 200 youth a year. About 200? So working with Dr. Janice Dion and her colleagues at Children's Hospital as well, she collaborated with adult providers and allied nursing in different agencies. We are starting to look at this tool. And so that section is what are the reports and assessments and consult letters that need to be part of that transfer package. Another component that's really important and really been driven home by our youth and families themselves and our adult partners is that youth and strengths concerns on transfer. And we started with strengths. What are their strengths in coming to your first visit in the adult world, but also what are their concerns? So you don't have to dig through all of the notes to find them. It's right there on the front page for you. I'm just going to talk a little bit about some of the skill building and the knowledge and information piece that we're working on through these pathways. If you look at the top line, it's 12 to 24. So when we started developing these tools, we were looking at the preparation, and when we went to our adult counterparts, they said, you're sending them really not done. I do a talk called The Half-Baked Cake, not to be derogatory at all, but from the outside, they look like young adults. They're driving, they've got their cell phones, and that's all going on. But really, they're not ready. So the adult care providers said to us, please send these checklists with them because we'll continue the work, and we want to continue the work. So skill building basically is around them gaining some skills and knowledge to be more involved in their healthcare and to be able to advocate for themselves, to be able to self-manage if they can. This is the medical transfer summary. These are the standardized core components to it that was developed with, I said, family docs and adult subspecialists. And the yellow areas are highlighted that the content is very specific to kidney disease. And again, these are in evolution, but hope to be a standard that we can roll out across the province. So it's great. I think the one thing that we've learned from families, again and again, please be more transparent, the youth themselves. Be more transparent to us. If you're talking about transition in a closed room, tell us what our issues are. We want to know how to plan and prepare for transition, and we want to know what you perceive to be our issues in not being able to transfer into adult care. So what we were working really hard on is making sure that those indicators in our transition pathway that are completed by the healthcare team are completely visible and available to youth and to families. So we have our tools online and they're being developed. The youth quiz is exactly the same indicators as on the staff tool, only in youth language. We're developing a family checklist for our more complex patients, and that will include information around housing. How do you start to access equipment? Things where you're into government granting and bursaries and all sorts of information. So a little bit more complex issues. The other idea about having toolkits, the toolkit's kind of the buzzword, but the reason the family said is put it online was because if I have a child that has special needs or I'm a busy person, I do not get to think about this till 11 o'clock at night. So youth themselves make it available to us when we want to do it. And I guess the other point to bring here is healthcare transitions cannot be done in isolation of other transitions. So we are working with groups in the communities that focus on school transitions. Because you need to have either they're going to school, how do they continue being integrated into their community? A lot of our youth, because they're part of the school system, really get isolated and quite left out when they leave the school system. And so we have to be really careful, make sure that we integrate healthcare transitions with living transitions, with school and or work transitions. So this is what the youth quiz would look like. And it's very similar to the components Mike brought up, Michael, sorry. Voice, being able to advocate. What are the skills they need around that? Being able to talk to, bring questions to a clinic visit, making sure their voices are heard. Can they describe their health condition to another person? Can they spell it? Do they know the names of their medications? Can they spell them? Really important, really important. Action, how do they do those skills? Can they go to the pharmacy and get medications? Can they order, can they get their blood work done? Can they pull up their blood results? Really important to youth is connections to all of us, that social support piece. Who is there for us for attachment? Who do we connect with? How can we not be isolated? Sexual health. We did a workshop with 9 young adults with young and T1, type 1 diabetes. They were so focused on this. The big things were funding and going to school, and the other thing was their sexual health and their genetics, and would they want to have children and pass that disease on to another. Future planning, we talked about the school piece. So basically what happens is, and we have the youth quiz online, and then we have the toolkit. If you take one item, describing my health condition to others, families said to us, break it down into small pieces so we can understand. So if you have a youth in your practice or a young adult and they aren't capable of doing this skill, which is pretty important, the toolkit will help them break that down into activities. So I'm going to show you how they can track it on their phone. They can go to HealthLink BC and learn about their condition, or they can go to the Sick Kids website, My Health Passport, which will walk them through a whole process of how do they describe their health condition, and really important items around medications, treatments, and it will print out for them a whole health history they can keep in their wallet. We also have printable activities. So online we have our youth toolbox. Within a month we'll have our family toolbox, and we are also working on our healthcare provider toolbox. And how do they all align? Our youth, one of our youth strategies and research projects, youth-driven research, was to go to a focus group of 9 youth from our Partners in Care Youth Advisory Council at BC Children's, and we basically said, does anybody have a phone? 9 out of the 9 pulled out their phone. So with their help, we developed a free app that actually already exists on your phone, and it's called Just Track It. If you go to your Notes app, teaching them to fill in their health condition, medications, allergies, questions they want to ask the doctor the next time they see them. And when we go into a waiting room, we always see our youth just sitting there with their heads down in their iPads or their phones. So this is an activity. If they don't do it at home, it's something could be prompted, and we're going to be prompting in the waiting rooms and at the clinics. The calendars, teaching them to go to the clerks at the children's site to book their appointments, taking that ownership. And their contacts. Who are all the pediatric people in their world? Who are all the adult people and community people? Pharmacy, again, labs. So that's what it might look like, very simply, on their Notes app. So I want you actually to turn, if you want to, you could turn your phones on. I think some of you might have them on. Now, I understand it's hard to get into, it might be hard to be able to, what do you call it? Sorry, get into the internet. But if you go to Sheraton Meeting, and then Kidney 14, all lowercase, you should be able to access the internet, and you can go on and punch in our website, www.ontracbc.ca. There's no dot before the BC. And that should take you to our homepage. If you want to, you can click onto the Youth Toolkit. And up will pop Just Track It, the toolkits, and the resource cards that help teach anyone how to start tracking their health and get engaged in their health. And if you just use that icon at the bottom and save it to your home screen, you have your own quick access to the ONTRAC website. So that is it for Sandy and I. We'd love to have questions from you. I don't know if we have time. Okay, and or comments, and we'd also, if you want to be engaged in this work, we'd really like to hear from you. Thank you.
Thank you very much. That was a great presentation, and a lot of great things coming down the pike, and things that I think are going to make it easier, and as you say, guide us to, as a community, figure out what's going to work best for our patients and how we make that work in our specific renal context. Are there any questions or comments as well? They said they're happy to have comments back as well. It doesn't necessarily have to be a question. I'm just going to start by asking maybe Sandy to just comment your timeline, including up till 25 years, I think is coming from more and more evidence about the neurocognitive development and things like that. So could you make some comments about why the extension to those kind of age?
Is this on? Yes. Yes. So, what is it? 50 is the new 60, so 20 is the new 30. I think that we know that there are societal pressures that are keeping younger people from being more financially independent longer, but there is a lot of information now about cognitive neurodevelopment, and particularly about the prefrontal lobe, which does executive functioning, and it not being mature until 25 or even 30 years of age. So the most important features around decision making and really sort of that understanding, engaging with the healthcare system, are not fully matured in that young, in that 18 to 25 age group. there's something else around society that I think that we need to think about and as adult providers, and that is that our young people are the most mobile and least financial group of and have actually a lot of and have very low flexibility in their ability to be engaged in healthcare. So, we sort of think that young people are free and have a lot of energy and things like that, but they lose benefits when they turn 18. They're going to be most likely in low-paying jobs. They move frequently. There's some data that sort of says between 18 and 25 you might move 7 times. So containing stability with a family doctor or healthcare is an issue. And if they do have a job, they're lowest ranking. So Bryn couldn't come because he had a job. And so attending appointments during regular daytime hours is actually incredibly difficult. So they're things that we often don't consider about young people when we think about providing the healthcare, and when we say that they're not engaged, actually the system makes it quite hard for them.
I just want to thank you for an excellent presentation, and I think it's amazing the parallels of transitioning from childhood to adulthood are not so different than all the different transitions within kidney disease, and even the cognitive impairment, which is so rampant in our patients, both for medical as well as emotional and psychological reasons, which makes it difficult to understand a complicated system. So I think that there's a lot that we as the adult nephrologists can learn from some of the tools, and I would unabashedly ask us to perhaps look at them and see if we can just use them with minor modification, because you've done so much work. And what we hear from everybody, irrespective of their education level, is how difficult it is to understand the system. So I don't think it's just children to adults. I think it's adults within the system that also can't understand it. So thank you very much for, in true spirit of partnership, sharing, and hopefully we'll do some work together.
And it's just a small comment about that self-management and co-management. I think that we are becoming more and more aware in the adult system as well that co-management is really critically important, and that people don't work or operate in isolation. They need their families and supports around them.
And maybe I'll just ask for comments. So you talked about resistance on transitioning being on a whole bunch of levels, but I guess for our learning and from the adult receiving sites of some of our patients, is there anybody willing to share with us some of the concerns or some of the things that you're worried about when you see a referral come from Children's Hospital for a patient that's been in our system for a while? Is there anybody willing to tell us what their concerns are or things so that we can try and make that better?
From our site, we see I'm from Kamloops, but we see so few of these come, so we might get a transition maybe 2 a year, possibly. And so it's very easy for them to just sort of get lost in the referral process and not the awareness of it. And just for some of the rural sites that might only be getting 2 a year or something like that, it may be worthwhile to actually contact us and not just send a letter. Because our teams actually probably should talk, because again, my team, who is so involved in looking after them, also doesn't think about this probably when they see it so rarely. And it may be worthwhile to actually have the conversation on the phone versus just the paper coming through. The other piece is that when they are coming to my site, it's likely because they're going to school and that sort of thing. So if there was an ability to add to that form, if the parent has healthcare coverage or something for them, because they don't know. And, they're coming with these medications, that kind of thing, and they don't know. And, a couple of times we've ended up finding out that they've paid for a bunch of things they didn't have to because they actually weren't aware that they were still under their parents' coverage.
Great point. Hello? Oh, sorry. That's a great point. It's actually on the face sheet. I'm so glad you brought that up. Financials, where they're going to school, travel, all those issues are on the face sheet of the transition pathway. Yeah. And I think that that's definitely an area of the callback, having supports at Children's, looking at your funding through fee codes, if there can be a way to have a call that you can that can be covered so that you can have that lengthy call on the transfer of care. Yeah.
So, there's an increase in telemedicine right throughout the province, and one of the things that we do know is that joint appointments are actually very valuable. The other thing that's valuable is actually seeing the adult provider before you've actually finished at Children's. So you go and you have your penultimate visit at Children's, you go to the adult provider, you go back to Children's, and then you move along. The reimbursement system gets a little mixed up about that, and we're having discussions with the doctors of BC about how this transition piece works, and it would be an adjustment for care, but we certainly believe that would help attachment, and it would give the young person the opportunity to go back to children and say, look, this happened and that happened, and for an explanation to occur because of those, to deal with those changes.